She went to John Muir High School and then to Occidental College and then to Case Western Reserve School of Medicine. She completed her residency in internal medicine at Huntington Hospital and then her fellowship degree at my alma mater, all of you, in 1992, where I did my GI fellowship. She has since then practiced infectious disease and tropical medicine at Huntington Hospital and in the Pasadena community. She's a faculty member and assistant director for the Graduate Medical Education Department at the hospital. And more importantly, she's the founder and director of the Phil Simon Clinic, a Huntington-based outreach clinic for underserved clients with HIV, which is a clinic in Tanzania. And every year she takes doctors and residents to Tanzania to serve that community. She is a fellow of the American College of Physicians, Infectious Disease, HIV, MA Association, with the International Travel Medicine Society. She's also a visiting scientist at the Huntington Medical Research Institute. So she has a special interest in zoonotic disease, global health, and like I said, has been just a great asset to the Huntington community. She did a Muslim family night with us in Pasadena, where we usually have it with Amir Al-Sarraf at the New Horizon campus, where we have our Muslim family night, and it was a great success. I think Dina heard about it, and alhamdulillah, she organized this. Again, Dina, thank you so much for bringing us all together.
Thank you.
With no further ado, I'll turn it over to Dr. Kim Schreiner. Thank you, Kim, for joining us.
Well, it's my pleasure, Waleed. Thank you very much. And Dina, thank you for the invitation. It's my honor to talk to you tonight about a topic that a year and a half ago I didn't know anything about. So, but now I've sort of learned a lot about this, and I hope I can share some of this information with all of you. I'm going to go ahead and if you can share, allow me to share my screen, Dina, is that possible?
Certainly, of course.
There we go. So needless to say, this is an ever-changing topic, and I'll try to give you the very most up-to-date information that I can, but it's also a very large topic. I'm going to focus tonight predominantly on sort of the few treatments that we have for COVID-19 and more importantly on the vaccines, but there are a few things that we need to pay attention to, and this is one of them. This was a very sad milestone that we passed a few days ago, with more than 500,000 Americans who've lost their lives to COVID-19. That is on top of 2.5 million people around the world who've lost their lives to this virus. And these are just not numbers. They are people with families and children and uncles and aunts and parents and grandparents and colleagues. And it really is a horrifically awful event that's happened to us. This is indeed something that doesn't happen to us very frequently, and is sort of in the realm of the 100-year pandemic, although I don't think it will be 100 years before we have our next pandemic. But I think it is important, as we talk about the science of coronavirus and the treatments and the advent of vaccines, that we remember all of the people that have perished from it and the families that have had to live with that. As we all know, just a little more than a year ago, China alerted the World Health Organization about several cases of an unusual pneumonia. And then a month later, a youngish woman died of a mysterious pneumonia in San Jose, California. And that was, of course, the beginning of this pandemic with SARS-CoV-2, which is the virus that causes COVID-19, the disease. We know it's a beta coronavirus. We know it came from what's called a zoonotic spillover event from bats. Prior to December of 2019, nobody on the planet had any immunity. It is very much the cause of the COVID pandemic. It is highly transmissible and very infectious from human to human. It's extremely dangerous and has had a terrible toll on our planet and on our societies. There are very limited medications used to treat it, and it clearly is not a hoax. It is the real deal. Now, we just recently recovered from really the worst surge of the entire pandemic. I've been practicing infectious disease for 30 years. I'm specialized in HIV medication, HIV disease, and so I know something about pandemics, but this has really been a challenging one. And the last 2 months, as I'm sure Dr. Shinde can attest to, were horrific. We had, at one point on January 17th in our hospital, we had 209 patients with COVID and 139 patients without COVID. We had ICUs scattered all over the hospital. The endoscopy suite where Dr. Shinde works a lot was turned into an intensive care unit. It was really, really bad. And thankfully, we seem to be over that surge. Hopefully, that will be the last big surge. It probably won't be the last surge, but we pray that it will be the last big surge because it was just really horrific. But it's normal for viruses like this to do this. And you can see what happened in this nice little graph that was made back in 1918 with the influenza H1N1 pandemic. They had similar things. They had some small surges and then wham, in about the fall and winter, they had this enormous surge. Things got better pretty quickly. And then they had another one later in the spring. So I think it's realistic to anticipate perhaps another, but hopefully smaller surge in the spring. Now, the big difference between the 1918 pandemic and now is that we have vaccines, which they didn't have at the turn of the last century. So that is an advantage. But for the last 12 months, we've really been living the consequences of this horrific pandemic. And I think it took a lot of us a while to realize that this thing was upon us, that this was going to dramatically change our lives for the next year or two. And it had a huge, huge impact on many aspects of society around the world. We know now that this pathogen is extremely infectious, that it is passed from human to human through droplets and through aerosolization of those droplets, and that it very avidly attaches to these nice little ciliated cells in your nose, the ACE2 receptor sites. We know that it is very aggressive. These are the spike binding proteins on the surface of SARS-CoV-2. They attach to ACE2 receptor sites in the nasopharynx and the respiratory epithelium. That's how the virus gets in. And of course, these are the areas where we have focused our attention for vaccines. We know that in addition to causing severe pneumonia and respiratory failure, that this disease affects many parts of the body, the heart, the brain, the intestines, the liver, the kidneys, and perhaps most importantly, the inflammatory system and the immune system. And you can see in this very interesting cryo-electron micrograph from Caltech, are these all areas of virus that are just located here in a cell. It doesn't take very much virus, but it is extremely dangerous and causes a great deal of disease. We've also learned that it affects people disproportionately. And once again, the poor have become the biggest victims of this disease. SARS-CoV-2 doesn't care what race you are or what ethnicity you are or what your age is or what your gender is. It just cares about going to a non-immune host. But we know that the lower socioeconomic people live in houses that have multi-generational homes. They may not be able to stay at home during a pandemic and not work. And so they're at very high risk for this disease. And that certainly has been a problem and something we have to continue to address, the equity that's associated with healthcare in this country. We know, however, we can control it pretty simply, but by wearing a mask, practicing social distancing, avoiding large groups of people, and washing your hands. Because it is an aerosolized pathogen, mask wearing is one of the easiest and perhaps most effective ways of controlling this particular pathogen. But most importantly, it looks like we may have found our way out. As I said, I think that was hopefully the last big surge we're going to have, but we still will be likely dealing with this disease for the next several 2 to 3 years, not on the same level, I hope. And we hope that with broad vaccination and good mitigation, the fact that masks are important, that the government promotes the use of masks and social distancing, that we can get on top of this thing and that we can resume some sort of normalcy, hopefully by the summer or the fall next year. Sadly, we really don't have much treatment for COVID-19. Unlike HIV, for which we don't have a vaccine, but we have very, very good treatment, this disease has been a challenge in terms of developing treatment. We've heard about all kinds of anecdotal things, all kinds of medications that have been revisited, some of which worked, some of which didn't work. And it's been sort of fraught with a lot of inaccurate science. And so we do have to try to look at studies that have been done to really recognize what treatments that we've done have been helpful. The United Kingdom recovery trial was one of the first that identified that dexamethasone, a simple steroid, actually seems to help both morbidity, sickness, and mortality, death associated with this disease, but it's not a game changer. The only antiviral medication we have still is remdesivir, which is made by Gilead Pharmaceuticals. It is the only approved antiviral. It may cut down on the length of stay in the hospital, but it really is not a game changer, and we desperately need better antivirals. Convalescent plasma has been very mixed. There was a large study, not a well done study. It wasn't blinded by any stretch of the imagination, but it is very unclear whether convalescent plasma really works. In my own personal clinical experience, I've had a pretty mixed result. Some patients do well with it. Some patients doesn't seem to make much of a difference. We do know that perhaps if it's used early in disease, if that patient has not developed antibodies of their own, it may help promote faster recuperation. Monoclonal antibodies, which are also somewhat controversial, again, have also not been proven to be very effective. They're very popular and have gotten a lot of attention because the former president received one set of those Regeneron, but they still don't seem to be very effective. We're always looking for monoclonal antibodies as an answer. It's sort of a medication looking for a disease, and it really has not been very efficacious. There are some early studies now done with bamlanivimab, which is the Lilly drug, that may be helpful, but really in the long run, they probably are not a game changer. Anti-inflammatory medications may be very helpful. Early on, we did use them. They didn't seem to show much change, but one of the drugs called tocilizumab was included in one of the recovery trials that were done in Britain recently and did seem to show a statistically significant difference in patients who received both tocilizumab, which suppresses the immune system, along with steroids. I have used it personally in a few patients and have had pretty good results, but we need larger studies to really identify better therapies. This is something that is brand new. This drug, EIDD2108, was mentioned many, many months ago, and I had sort of seen it in a journal, and then it kind of disappeared. It turns out that Merck bought it. It's actually a drug that was originally designed for influenza, but it seems to have very good activity against SARS-CoV-2. It's an antiviral, and the best part about it is that it's oral. And so we can give it to patients early in disease and perhaps stop the disease from progressing, much like we use a drug called oseltamivir, Tamiflu, in the setting of influenza. It also could perhaps be used as a pre-exposure or post-exposure treatment for individuals who've been exposed to COVID and are not vaccinated. So this is a drug to keep an eye on. Merck had a couple flops when it came to vaccines, but they are now in charge of this drug, molnupiravir, and I'm sure it'll come up with some other equally unpronounceable name. But it does appear to be very intriguing, and it's entering phase 2 and 3 trials right now in humans. So let's talk about the vaccines, because that really is going to be our way to get this thing under control. Very quickly, when it was recognized that we probably did have a pandemic on our hands, way before WHO actually declared it a pandemic, the Chinese government released the genomic sequence for SARS-CoV-2. This was actually a very, very good and helpful thing to do. They were a little slow to the start there in terms of revealing where this disease may have come from, but they did do this, which is a great service to science. By doing that, it allowed scientists around the world to see the genetic sequence for this virus. And it was recognized very early that a vaccine was going to have to be the way we could get this thing under control. And most importantly was the section around the spike protein, which is the attachment site for all coronaviruses to human tissue. And so that was a very important event. The next day after the Chinese released this, and they just basically put it out on the internet. You could Google genome for SARS-CoV-2, and there it was. Dr. Barney Graham at the National Institutes of Health, a colleague of Anthony Fauci, saw it, and he and his colleagues started right away modifying proteins that could be used for a vaccine. 2 days later, they gave that to a little company called Moderna that was very interested in developing messenger RNA type vaccines, and I'll talk about those in detail in just a little bit. And so Moderna had that information very early during the pandemic. And that was important because it would allow them to start designing a vaccine that hopefully was going to be effective. So what is a vaccine? Well, a vaccine is an injection or substance that, when introduced into your body, stimulates your immune system to create protective molecules, often what we call antibodies or neutralizing antibodies, or cells to prevent you from acquiring or getting sick from an infectious disease. And all of us are familiar with vaccines. We've had vaccines for measles and for diphtheria and tetanus and hepatitis. So vaccines are a part of our normal medical care. What do? They protect an individual from an infectious disease. They protect a community from spreading the infectious disease. And occasionally vaccines are used to treat infectious diseases. So for example, with Ebola, there's some very good vaccines now that not only protect you from Ebola, but can actually treat the disease if you actually get it. So that's an interesting use for vaccines. What are the requirements for a successful vaccine? Well, obviously we want it to be safe. We want to have it well studied. It needs to be very specific for the pathogen that we're concerned about and for the part of the pathogen that's the most important mechanism for that pathogen to get into the body, in this case, the spike protein. We want to make sure that it elicits a robust and lasting immunity in all age groups and all risk groups, and that would include both antibody production and cellular immune response. It needs to be well accepted by the public. You have to be able to scale it up and produce it in large quantities. That's especially important right now in the middle of a pandemic. It needs to be transportable and storable. That's a bit of a problem with the mRNA vaccines. And the vaccine should have limited side effects. How do you administer a vaccine? The conventional way is intramuscularly, but we can also give vaccines subcutaneously. You can give inhalational vaccines. We have one for influenza. You can give oral vaccines. Many of us remember the oral polio vaccine. The typhoid vaccine has a nice oral version. And you can even do novel techniques such as microneedle administration. This is actually something that's being looked at for the Novavax vaccine, which is likely to be approved in the next few months. And what you hope to see, that it's well tolerated, that it has minimal side effects, that it produces less disease in the population that is vaccinated than in the unvaccinated population. And again, that it stimulates the immune system to respond very robustly to even the most severe levels of the disease and prevent that disease from causing hospitalization and death. So how do we know that these vaccines have worked? I think one of the concerns that many people have is that, well, these are new vaccines. This is a new technique. It isn't really a new technique, and I'll explain why in a couple minutes, but we do have animal data that was collected very early in the pandemic. These were rhesus macaque studies in which they produced a DNA vaccine, and they showed very quickly that, that the macaques, the monkeys that were vaccinated with the vaccine, didn't get SARS-CoV-2. Rhesus macaques can get SARS-CoV-2. So it was an important study to be done. And it also showed that they had a good response both with their humoral immunity, that's their the antibodies, and cellular immunity. So that was sort of the proof of concept way back. The study was done in the spring. It was published late last summer. Then you have to move over into human trials. And so this is just the 3 different types of trials that are set up to study medications or vaccines. You have a phase 1 trial, which usually is a small group of people, about 100, and that looks at the safety of the medication or the vaccine that you're using. Then you move on to the phase 2 trial that looks at a larger population, again, assessing safety and perhaps a little bit of information about the effectiveness of the vaccine or the medication, depending on what you're studying. And then you move to a large trial, usually 30,000, 40,000 people. During this time, an independent review board is monitoring the data. They don't belong to the pharmaceutical companies, and they are the only ones that know who received the vaccine or the medication and who received the placebo. And so they're monitoring the data during this process of these phase 1, 2, and 3 trials. Now, one of the reasons why these vaccines were able to be tested so quickly is because we're in the middle of a pandemic. We've got lots and lots and lots of disease. Normally, vaccine trials take about 5 to 6 years to test, because it's often things like hepatitis B, for example, or human papillomavirus, or even more obscure diseases like Ebola, of which there isn't very much compared to SARS-CoV-2. But these vaccines were developed in the setting of a big surge during the summer. So you've got this trial going on where you've got healthy volunteers, half of whom receive a placebo, half of whom are receiving the vaccine, and they are living in a world that's surrounded by COVID-19. And then you want to see how many of the people actually get COVID-19. Again, all of this is being monitored by safety boards and internal institutional review boards. And you want to be able to evaluate all different types of gender and age and ethnic and racial differences, because those are the people that get. We want to make sure we have a broad heterogeneous group, because that's what society is. I will tell you that people who participate in trials tend to not always reflect the community. They may be older, they may be more educated, they may be more believers in science. And so sometimes we have disparities in who we recruit, but these, especially Pfizer and Moderna, and Johnson & Johnson for that matter, have made a great effort to really try to have a diverse group of people. It is very hard to do initial studies with brand new types of interventions, i.e. a brand new vaccine in children. And so that's being done now, but that's a problem with these. It's hard to recruit kids for these studies, and it's difficult to do from ethical standpoint. So there are some gaps in our knowledge, but we're beginning to put those together. These are the different types of vaccines that are being currently still in development and or have developed all around the world. Remember, China and Russia are also producing vaccines. India is producing vaccines. And tonight we're just going to focus on these two, the nucleotide-based vaccines, which are the mRNA vaccines, and the viral vector-based vaccines, which is what Johnson & Johnson and AstraZeneca vaccines are. All these vaccines are directed towards the spike protein. There are a couple that include some other parts of the spike protein, the base of the spike protein. But for the most part, they're really directed towards that part of the virus, because that's the most effective way to prevent its infection and transmission. So we're going to look at this family of vaccines, which are the mRNA vaccines. There's also some DNA vaccines out there, and then the viral vector vaccines, which is what the Johnson & Johnson and AstraZeneca vaccine are. AstraZeneca has been approved in Europe. I don't think it's going to be a big player here in the United States, because we have 2 vaccines already, soon to have 3, probably tomorrow. And we also have Novavax, which is a subunit vaccine, similar to the hepatitis B vaccine that's going to be coming out probably in the next few weeks. But there are other vaccines in the world right now. Sinovac and CanSino are 2 vaccines out of China that appear to be effective. Those are adenovirus vaccines. And then, of course, there's Sputnik 5 or Sputnik V, I think it's a 5, which they had a very small phase 3 trial, shall we say, but it does appear to be safe and effective. So it'll be interesting to see how that plays out going around the world in terms of helping other countries that aren't developing vaccines. So let's talk briefly about the mRNA vaccines. This is a time for recognition of the incredible work by 2 women scientists. I think if you have some young women that are watching this tonight, this is a great time to go into science for women. I think that this speaks to the power of equality and gender equality and recruiting people to do unusual things. These 2 ladies, Dr. Katalin Kariko, probably will be a Nobel Prize candidate this year, I imagine. She is the person that helped originate mRNA technology 20 years ago. So it really isn't new science. But Dr. Kariko was the person that studied how to get the genetic information into cells without the cells destroying it before they reached the target area. Dr. Kizzmekia Corbett is working for the NIH. She's a colleague of Dr. Anthony Fauci, and she's been pivotal in developing the Moderna vaccine. So really an important recognition for people that have normally not had many opportunities in science. I think that this is going to be hopefully change as we move forward with more women in these fields. But mRNA technology, as I said, has been around for 20 years, thanks to Dr. Kariko. It appears to be very safe. It doesn't harm the host. It has been looked at in other vaccines, HIV. HIV is a whole different kind of virus, very hard to make a vaccine for. Didn't work there. Was developed for Zika, but then the Zika pandemic sort of fizzled out and has been looked at for respiratory syncytial virus as well. So this is the Schreiner diagram on how an mRNA vaccine works. What we're going to do, first of all, is, here's the spike protein here on the outside of a coronavirus. And we want to teach the cells in the immune system that make antibodies how to make antibodies to the spike protein. So what mRNA vaccines do is you take a spike protein off of a coronavirus and you get the recipe for it. This is the genetic code for that spike protein. And you wrap it in a little oily membrane, and that allows it to go into the cells in the body. So it goes into the cells like this. It stays out in the cytoplasm. It never gets into your genetic material. This genetic material never mingles with your genetic material. But what it does is this is a recipe for the spike protein. It tells this cell to make spike protein. So now we're making spike protein, but we don't have the whole virus there. So it's not going to hurt you. It's just little pieces of spike protein. And that then goes out into your body. And along comes your immune system, your B cells and your T cells. And they go, wait a minute here, what's this? This is something foreign. So I'm going to make antibodies to that. And so it makes antibodies to the spike protein, and it destroys the spike protein. So when another real virus comes along, now your body knows what that is and says, wait a minute, that's the spike protein. I'm going to make antibodies. And so it starts making antibodies to that virus, and it kills the virus. And that's how an mRNA vaccine works, very simply. They're fragile, and that's why they require such intense cold storage, because of this part of the process of the vaccine. This is different than a virus vector vaccine, which I will show you in a little bit, but that's how an mRNA vaccine works. Well, what are the advantages? They're very safe. And I think, up at this point, we've had 52 million people in the United States receive either the Pfizer vaccine or the Moderna vaccine. Very, very, very safe. We've had a few cases of anaphylaxis, none of which have killed anybody, only a few of which, perhaps less than 5, have required hospitalization. So these vaccines are incredibly safe. There's no risk of infection or what we call insertional mutagenesis, where the vaccine could cause cancer or genetic changes. It's all degraded by normal cellular processes. You can fine tune these vaccines. You can dial in different recipes, which we might have to do as these variants become more prominent in our environment. They're very efficient at delivering carrier molecules. So this technology can be used not only for vaccines, but also for things like antibiotics or cancer chemotherapy to deliver a substance to a very specific area. There's very limited amount of immunity to the actual vector that's carrying it in. The little oily membrane that carries this information in doesn't stimulate your immune system itself. And you can make them very quickly. You can scale them up and make lots and lots and lots of these vaccines very quickly. And you're seeing that happen right now when we had this sort of shortage of the vaccines, that we are going to have a boatload of vaccine next week. I was at the Pasadena Public Health Vaccine Conference this morning, and they're talking about huge shipments that are going to come in from both Moderna and Pfizer. What are the disadvantages? Well, they've never been tested in the pandemic, but we're doing it right now. There might be some unforeseen issues that we didn't predict. That can always happen. Doesn't seem likely. The in vivo immunogenicity has not been well tested in humans. That's what we're doing right now. We've had a couple of little failures with some of the other vaccines, and we don't know how long these vaccines are going to be good for, but we're beginning to get that information. So for the mRNA vaccines, they require 2 shots, a prime and a boost. Pfizer, it's 3 weeks apart. Moderna, it's 4 weeks apart. A lot of questions I get, well, what if I miss my second boost? Or what if I make it longer or shorter? Is that going to be a problem? And the answer is there's probably a lot of flexibility here. It may well be that this in and of itself, and I will show you why, is going to be good enough because you get really pretty good immunity just after the first one. But we really want to lock in that immunity with the boost dose. Whether that's exactly 3 weeks apart or 4 weeks apart or 12 weeks apart, we don't know, or even never given. That's a possibility. But right now, these vaccines are set up in this fashion. Johnson & Johnson is just one vaccine. There's not a boost with it, which is a huge advantage when you're talking about vaccinating the entire planet so that you don't have to do it twice. Both the Pfizer and Moderna trials were very big. They were 43,000 in the Pfizer group, 30,000 patients in Moderna. Johnson & Johnson's group has 44,000 people. These are big trials, and they really are remarkable findings, is that in both of them, these two mRNA vaccines, they turned out to be surprisingly effective. We were expecting 60 to 70%. That would be terrific. That's what the influenza vaccine is, sometimes actually even less than that. But that's good enough to confer immunity to people. These turned out to be 95% effective. So very, very effective, no severe diseases, and very good at preventing not only illness, but also death. This is the actual data that shows these are the placebo people that were getting COVID like crazy. Here's the group of people that were vaccinated. This is the Pfizer data. Antibody responses, very, very good antibody responses, even after the first vaccine, very high levels. I did sort of a cartoon of this so you can see it. Here's your first vaccine. Let's say this is Pfizer. Within 8 days, you've already got 40 to 50, 60% of antibodies circulating. So that's why one dose may actually be good enough. By day 21, before you're going to get your second dose, you're already up to 65, 70%, 80%, which is very, very good immunity. Then you get the second dose, you bop up into the 90s. That's excellent. That may be better for the longevity part of things. And you can see that it's better than natural infection. And so that's why we recommend that people who have had COVID still get vaccinated, because the vaccines are more immunogenic. How does it respond in the cellular immune system? Equally good. Very, very high levels of T cell response and B cells. B cells are the guys that make the antibodies. T cells are the ones that sort of are the policemen of the immune system. Very good response in both of these vaccines, as well as with the Johnson & Johnson vaccine. Well, what are the side effects? Well, lots of people have sore arms. I had a particularly sore arm. In fact, the night I was giving this talk to the Muslim family night, I shared with Dr. Shindi that night I was actually having some sort of chills because I had gotten my second vaccine. So fever and chills are common, usually after the second shot, if it's a dual shot vaccine. You can have kind of some flu-like symptoms, muscle pain, joint pain, Swollen lymph nodes have been reported and are actually fairly common. They're benign. They don't have any malignant kind of potential. And usually those things resolve after a couple of days. Some people have very bad headaches, and you kind of feel a little punk and maybe tired for 2 or 3 or 4 days, but really those resolve very quickly and it's not a big deal. As I mentioned, there have been some severe responses to these vaccines with anaphylaxis. They're very rare. If you have a history of severe allergies, if you're very allergic to shellfish or your throat has closed up with some medication, you need to discuss that with your doctor and they need to tell the vaccinator and they will watch you very carefully. Can people with a history of anaphylaxis get vaccinated? Yes. And again, we know that COVID-19 is a very serious, very deadly disease. And so the benefits of these vaccines far outweigh any risk of anaphylaxis. And as I said, there have been very few cases, no deaths, happily. And so that is something to consider, but not be too worried about. This is the Johnson & Johnson vaccine. As I mentioned, it's not an mRNA vaccine. This is a more traditional vaccine platform where the genetic material, this is DNA instead of RNA from SARS-CoV-2 is put into another virus. In the case of Johnson & Johnson, it's an adenovirus. In the case of the AstraZeneca vaccine, it's a chimp adenovirus. And what happens is then this little vector transporter gets taken up by a cell in your immune system, and it actually inserts the genetic material into the area here in your nucleus, and it causes that to make antibodies to the spike protein. This is, again, the recipe for the spike protein. So this is a very traditional way of making a vaccine. A lot of the influenza vaccines are made this way. Many of the COVID vaccines that are made in China are adenovirus vaccines as well. The advantages are it's one shot. Again, it was a very big trial. And what's interesting is that, this was completed just a few days ago. These trials were done in Brazil and in Chile and in South Africa and in Mexico. And so Johnson & Johnson has a much more diverse participant population, which is a good thing. It's much more reflective of sort of humanity, perhaps, than the mRNA vaccines. What were the results? Well, it was 66% in preventing mild to moderate disease, 77% in the United States, but worldwide about 66%. I worry that people are going to see this number and compare it with the mRNA vaccines and say, oh, well, I want the mRNA vaccines because they're better. No, they're not. These are equal numbers. This is a very, very good number. If this had been the first vaccine that had come out, we would have been jumping for joy because that's very, very good. It's highly effective in preventing severe disease, which is excellent. And it's 100% effective in preventing death. And these are the two factors that are perhaps the most significant ones right now in preventing these terrible numbers that we're seeing at the hospital. Also, this virus vaccine was developed during now the presence of some of these variants, which may reflect why these numbers are a little bit lower, but they still show efficacy. So we know that even in the presence of some pretty significant mutations, such as the South Africa variant, this virus was effective. I'll go back to this. And it may be effective to new emerging strains as well. In addition, Johnson & Johnson is one of the few vaccines that appears to right now show decreased viral shedding in people who are asymptomatic carriers. And this is a very important factor in terms of controlling the spread of the disease in the community. We think that is true for the mRNA vaccines as well. Pfizer has shown that a little bit, but that data is still forthcoming. But it's certainly been shown with the Johnson & Johnson vaccine. Perhaps most importantly is it doesn't require the same cold storage characteristics of the mRNA vaccines. It's much more robust. It just requires normal refrigeration. So this is going to be a vaccine I think we use largely in developing countries or resource poor countries that don't have good refrigeration. And finally, and perhaps most importantly, there's not been any cases of anaphylaxis. So if you do have anaphylaxis and you're really worried about that, this may be the way to go. This is an excellent vaccine, and we want people to access it if that's the first thing that they can get to. So who's getting vaccinated? Healthcare workers, skilled nursing facilities. Some very good news out of this population. They were very early to get vaccinated. In some data coming out of New York, just an absolute precipitous drop in the number of new cases of COVID on the East Coast, both in New York and Connecticut. And indeed, even here in Pasadena, I have several friends who are hospice workers, hospice social workers. And in many of the nursing homes that are around here that had terrible COVID outbreaks, not one case in the last 2 weeks because all the residents are vaccinated. So, and their care workers, which is perhaps the most important piece. We're fast moving through these tiers. Huntington has been involved in creating a very effective vaccine clinic. We're doing about 500 vaccines a day. So we're up to, I think we've vaccinated about 15,000 people now. City of Pasadena is doing large vaccine clinics. And of course, the federal government has now stepped up. They're recruiting the Army and also a National Guard for very large mass vaccination sites so that we can get people vaccinated as quickly as possible. That's super important to get this pandemic under control. You've got to get the virus down and suppress it before it develops a mutation that allows it to escape the vaccine. So I think everybody will probably have access to a vaccine really in the next, by the end of March or April, regardless of what your age is or your occupation. So a few groups. At this juncture, the study is being done with women. About 9 individuals in the Pfizer trial became pregnant during the trial, had perfectly normal pregnancies. COVID-19 in pregnant women is a bad thing. It has a very high mortality. And so the advantages of the vaccine far outweigh the risks in pregnant women. It's being studied specifically in pregnant women right now with both Pfizer and Moderna. But I think most of the gynecologists, the American College of Gynecology and Obstetrics, has certainly recommended that women have access to the vaccine, that if they are, especially if they're in a high risk population, let's say they're an ICU nurse or a respiratory therapist or a physician, that they should get vaccinated because it will protect them. It probably will protect their baby as well. Immunocompromised people, it's a safe vaccine. These are killed vaccines. There's nothing live about them. So they can be used in patients with cancer chemotherapy, HIV, immunocompromised autoimmune diseases, and so forth. Children, studies being done now with Pfizer of ages 6 to about 12. I think it's going to probably be very safe in children. Little kids under 6 generally don't get the disease very well and aren't that sick with it. We have had a few cases of this multisystem organ issue, but that's very rare. So I think probably they may cut it off at about 6 years old, but I think in young children who are very effective spreaders of disease, it will be important to vaccinate them. People with neurologic disorders, it's probably safe. We have to watch them a little bit carefully. There were 2 cases of neurologic events in the AstraZeneca trial. They were deemed not related to the vaccine, but it is something to keep in mind. And we discussed the anaphylaxis thing. So what does it mean when you're vaccinated against SARS-CoV-2? Well, it means that your immune system will recognize the virus as a pathogen, as a bad thing. You will develop neutralizing antibodies and activate your immune system that will confer immunity to the disease. Now, remember, not everybody develops immunity with every vaccine. We know that sometimes people don't get immune to influenza with the flu shot, but most people do. So, and some people may have higher levels of immunity than others, but they may have enough to protect them from severe disease. You will be significantly less likely to, or prevented from developing severe disease requiring hospitalization. And most importantly, you will be significantly less likely to die from COVID-19. Probably all these vaccines really protect you from that for sure. You may be less likely to spread SARS-CoV-2. We think that's true. We just don't have all the data in yet. This was some data that was published in Lancet that came out of Israel. They have had a very aggressive vaccination program. And basically what they've shown is that even after first doses, there was a huge decline in cases. So we know that vaccines in and of themselves can affect the pandemic, not just natural disease, but that the vaccines really seem to show a substantial reduction in infection and symptomatic COVID-19. That is very important even after the first shot, so that if you can't give a second shot, let's say it's a resource poor country, that at least the first shot is going to confer enough resistance to really cause a decline in the vaccine. This is sort of the big question. We don't really know how long these vaccines are going to be good for. That's an advantage to having a boost shot because it may confer longevity to immunity. Or we're going to have to, like we have the flu shot, maybe once a year or once every 2 years, get a COVID shot. That's a possibility as well, unless the thing just disappears completely. So we don't really know the answer to this, but it does appear that people retain immunity when they've had COVID for about 11 months now. That's about how long we've been able to measure it. And the vaccines are probably even better than that. So I kind of think that this is not going to be a yearly thing, but we may have to dial in a new sort of booster shot because of this problem. We are now seeing, the emergence of mutations and variants. This is a normal thing to happen with coronaviruses. They're very inaccurate replicators. They make a lot of mistakes when they replicate, and they replicate and they mutate when they're replicating. And the most common place for that to happen is in the receptor binding domain, the part of the virus that attaches to the ACE2 receptor, this part of the spike protein, and it attaching down here. And so all of these mutations that you hear about, these numbers, the Bs represent lineages of the virus. These are families of virus, and then this is sort of a branch of it. But these are the actual amino acid mutations that happen. So the B117 is the most prevalent one now in the United Kingdom, probably in Europe, and actually in the United States, probably it's fast becoming more the prevalent mutation. This is the one we're particularly worried about because it tends to be a little bit less captured by the vaccines. But I will tell you right now, anyway, we think that all of these mutations, including the one that I'm going to talk about in a second, appear to be captured by the current vaccines. Will we need to have a booster, or will they have to adjust the recipe a little bit? Maybe, just to make sure that we stay on top of it. But this really speaks to the importance of doing genomic sequencing and assessing the virus and its evolution, because it will evolve. It also speaks to the importance of getting as many people vaccinated as possible. All of these mutations make the virus more effective at attaching to their ACE2 receptor site. It opens up this little area on the receptor binding domain. It allows it to attach much more ferociously. That allows the virus to start replicating very quickly, have very high viral loads, and then that translates into worse outcomes and more virulence. So that's why more infectious pathogens are also nastier. And that's certainly the case with some of these mutations. We now know that California has two mutations that are circulating, the 1427 and the 1429. And you can see here, this is Northern California, a predominance of their virus now are these two mutations. This is Southern California. We even have more. And I have to say that looking back on what happened in December and January, where we just had this horrific tsunami of disease, a lot of us thought, well, that's because we had Halloween and Thanksgiving and Christmas and New Year's and everybody getting together. I think that was driving it to some degree, but I do think that this variant was out there and is much more infectious, and so it was just causing much more disease. I really felt like at the time there was something very different about this pandemic. One of my colleagues whose kids go to New Horizon, we were talking about this the other day, is that also patients were much sicker. They had all kinds of more significant pulmonary problems than perhaps the ones we'd seen during the first couple surges. So I think that speaks to the fact that the variants are there and they're causing more disease. So this is fresh off the press from yesterday. This is Pamela Bjorkman's lab right here at Caltech. This is a New York City variant, which is fast becoming the dominant variant in New York, likely to spread through the United States. This is something we're going to have to keep an eye on. It appears to be very infectious and may not be captured by as well as by the vaccines as the other ones are. It has very similar mutations to the South African variant, so we're going to have to watch it very, very carefully. But Chris Barnes and Pamela Bjorkman are over here at Caltech doing some great work on genomic sequencing and monitoring of viruses as they emerge. So we do know that the vaccines do seem to work for these variants, which is good news. This is a little study that was recently published as a correspondence in the New England Journal with the Pfizer vaccine. The level of the neutralizing antibodies were diminished, but they are enough and effective enough probably to keep people safe. We don't know what's happening with the cellular immune system. That's a little harder to measure, but we think that probably at this point, all of the vaccines we have available will be good enough if we get people vaccinated fast enough to keep this thing from developing into a bigger and nastier virus. As Dr. Fauci said at the earlier part of this month, that viruses don't mutate if they can't replicate. So we've got to get everybody vaccinated as fast as possible. And everybody means not just everybody in the United States, everybody in North America, everybody in the Northern Hemisphere. It means everybody on the planet. If we have countries that don't have access to vaccine, where the virus is mutating and replicating, it could easily transform into a mutant form that is even nastier than the one we've got right now. And we'd be right back at the start of the whole thing. So it's really, really important that we reach out to the entire globe and get this thing taken care of. I want to mention briefly herd immunity. As Dr. Shinde said, I spend quite a bit of time in Africa. We're there often during the migration. This is a herd of wildebeest and zebras. This is the Pfizer group, and here's the Moderna group over here. But herd immunity is basically when you achieve a level of immunity in a population that prevents the pathogen, the virus in this case, from moving through that population. And that can be achieved either through natural infection, which takes a very long time and can have devastating effects. In this case, with a virus that has this high mortality, we would have had even more deaths than we've had. Or you can do it with a combination of natural infection and vaccination. And so by looking at those two parameters that we're doing and by ramping up this vaccine chart, and frankly, I have to say the Biden administration, this is even accelerating very quickly. So it's possible that this may shift over this way. So we achieve this range where for this degree of an infectious pathogen, we have to get about 70 to 80% of the herd immune to basically stop the pandemic. But we may achieve that sooner than we thought because of the rapidity with which the vaccines are now being deployed. And one thing I'm very pleased about is that people seem interested in getting the vaccine. I know we have a lot of people who are concerned, who are hesitant, who may have religious reasons or philosophical reasons for not getting vaccinated. But I really have to say, for the most part, we've had very good responses. We want people to take these vaccines. They're safe. They're going to protect you and your family and your community so that you can have a much more normal life down the road. What's the future going to bring? I think we need to pay attention to this. This is not going to be our last pandemic. I pray that we don't have another pandemic soon, because this one's been really a beast to get on top of. But it's going to give us we have incredible accomplishments here with the development of these vaccines in a very short period of time. We identified the pathogen, we developed an effective vaccine, and we're going to get this thing under control within about a year. And that is a huge, huge achievement. And that speaks to the power of science and facts and equity. So there may be some ways of making vaccines where one vaccine covers many different types of viruses, a pan-virus vaccine. That's been looked at for influenza, and that certainly there's going to be some research into that down the road, I think, in terms of covering all coronaviruses perhaps, or many different types of viruses that could cause pandemics. So this is going to be a very interesting and important field as we move forward. As I mentioned, we have to vaccinate the entire planet. This is a disease of humanity. And so for countries that can't afford vaccines or who don't have the ability to deploy them, it's up to developed countries to step in and do that. The World Health Organization has formed COVAX, which is a world international organization to supply vaccine to underserved countries and get everybody vaccinated. It's very, very important that we do this as quickly as possible so that we don't have pockets where the virus can continue to replicate and mutate. So if you're vaccinated, why do you still have to wear a mask and practice social distancing? Well, although you may be protected, you still could possibly carry the virus and pass it on to somebody who either hasn't responded very well to the vaccine, who didn't get the vaccine, or for some reason is a non-immune host. Most people at this point haven't been vaccinated. I think it's about 5 to 10% of the United States now has received their first vaccine. Not everybody has a strong response to vaccines. The emergence of these variants are a real threat, so we have to be very, very careful. And we still don't know very much about this virus. It's a brand new virus. We've never had any experience with it. I've been an HIV specialist for 30 years. I know a lot about HIV. I knew nothing about this until it hit. So we have to be very humble in its presence and try to learn as much as we can so that we can stay on top of it. And I hope that the legacy of all of those people that we have lost and we will continue to lose until this pandemic is over, that their legacy will be, we've learned so much through truth and science and equity, so that when we have our next pandemic, we do a better job at getting under control and decreasing the number of people who suffer and die from this disease. Finally, I just want to make a mention, if we can land a car on Mars, which we did last week, then we can get on top of this pandemic. We have incredible tools as scientists and researchers, and our ability to be creative and do enormous challenges. But this is our only home right now, and we have to take care of it. We have to pay attention to our environmental impact, the inequities that we have in society, to reach down and lift up people that are less fortunate than we are, to have better communication with people who are different than we are, and to be better stewards for the planet and for animals. Then we will be able to control the future pandemics as they come along. So with that, I would like to thank all of you. These are my references, and I'd be happy to take questions.
We have several questions for you, Dr. Schreiner. Thank you first and foremost for a very, very informative presentation, a lot of meaty information there. And as you can imagine, there are some questions that we'll go ahead and go through. In which stage do doctors start offering these medications? Is it just the medications that you were talking about for treatment for those who get, so this was early on in your presentation. Is it after the patients get admitted to the hospital?
Well, we don't really have much in the way to offer people as outpatients. Now that may be changing with molnupiravir, the EIDD 2108. Once that gets approved, that turns out to be helpful. That could be a drug that an internist could give to their patient if they, think they have COVID, and stop it, early on. And that would be super helpful. That would prevent admission to the hospital, much like we use Tamiflu to diminish influenza. So we're hoping to have medications like that, but right now we don't have that. The monoclonal antibodies have been used a fair bit lately for people in early stages of the disease who are at high risk for progression. So they have diabetes, or they have hypertension, or they have COPD or something that's going to give them a bad outcome. Those drugs are intravenous only, and they have to be done through an infusion. They're given once. They're very expensive. They're $2,700. There are companies, Corum and CVS, I think, are both doing them at home. Many of our internists are doing that for their patients. It's a little bit of a drug for people with resources, and that's bothersome. Again, that sort of accentuates some of the inequities. We've started a program at the hospital to reach out to our underserved in our clinics if they would qualify for the use of, the only one that you can do that with right now is the Lilly drug, bamlanivimab, these unpronounceable names. But they're not game changers. They're sort of okay. Everybody wants monoclonal antibodies to work. They've been around for a long time. They just don't seem to pay off like we want them to. So I think antivirals, as we move forward, are going to be important, and maybe the Merck drug will be the first of those.
Great. Another question, do people with heart disease need doctor consultation before taking vaccines?
No. And people with heart disease are at high risk for having a bad outcome if they get COVID. COVID does affect the heart. And so you want to talk to your doctor and just say, do you think I should have the vaccine? I can't imagine any doctor would say, no, you need to have the vaccine, and you're at high risk for a bad outcome. So the vaccines themselves don't cause any problems with your heart.
I believe you did answer this one. If the period of time between the first and second dose of Pfizer is 30 days instead of 21, would that impact the efficacy?
Thankfully, to our knowledge, the virus can't count. So I don't think it's a problem. No, I know people are kind of, nervous about that. And we had a little hiccup because we sort of ran out of vaccine last week. And then, of course, all the stuff that happened back east with all the ice storms that delayed transport of vaccine. So there's some people that are, getting their vaccine, their second shot a week or two later. It doesn't seem to matter. And in fact, maybe that's a better thing. We don't know, or even, certainly you have enough immunity after that first shot to really give you pretty good protection.
This individual is in their 50s, so they're just under the age bracket to receive the vaccine currently. They plan to travel outside of the US in April, and they're wanting any advice that you could provide to receive the vaccine before their travel.
Well, I think they will have access to the vaccine. Sort of under the radar is the fact that, like I said, there's going to be a huge delivery statewide in the next week. And so I think there's a lot of impetus to open up all the tiers really within the next couple of weeks. So if that person hasn't, even if they can get the first shot, or if they can get the Johnson & Johnson shot, they have 4 million doses ready to go right now. They're scheduled to deliver 100 million by the end of the spring, I think. So we're going to have 3 vaccines available. And I think before that person travels, they will probably at least have gotten their first shot, which I highly recommend. When you get your vaccine, you get a little card that says you've been vaccinated. Many countries require either you certainly have a COVID test, and or go into quarantine and have a card of vaccination. That'll sort of is a good thing to carry. I recommend that people take a picture of it on their phone so they have a couple copies of it.
Great. Do you know if the public will have a choice of which vaccine they can take once it becomes available and eligible?
It's possible. I think we may have a lot of vaccine by the summer, and then you can sort of choose, but it doesn't really matter. I just, whatever you can get first, get it. If it's the Johnson and Johnson vaccine, get it. It's good. If it's Pfizer, get it. If it's Moderna, get it. Just get something on board as quickly as possible. Don't wait and shop around. One's not better than the other. And I think that's going to be a hard thing to sort of convince people because of the mRNA vaccines have the spectacular efficacy rate, but they have some problems. I mean, they may not be as good with the variants. They weren't tested when the variants were really prominent. So the Johnson & Johnson has that on top of the other two.
Yeah, another question about that. Do you think that the J&J vaccine would have a negative effect on one's DNA?
No, those that's a very well-studied kind of platform. And when you think about it, with the exception of the very first polio vaccine, which caused polio, that was a live vaccine. The Salk vaccine was actually kind of a dangerous vaccine. 15% of people who got it actually got some degree of polio. The Sabin vaccine was the inactivated vaccine. That was the better vaccine, and Salk won the Nobel Prize, unfortunately. But vaccines are, of all the things we do to patients and for patients, vaccines are the safest thing. We give people all kinds of medications. Antibiotics can be dangerous. They can do all kinds of terrible things. Diabetic medications can harm people. Blood thinners, God knows those drugs cause all kinds of problems. And we prescribe those all the time to people. Vaccines are very, very, very safe. You don't hear about someone who's developed some terrible ailment 10 years later because they got a vaccine. I know that there's a lot of controversy about autism and stuff. That has never been shown to be linked to vaccination. They are very safe. So, and we know that COVID, even if you get mild COVID, some people are having these long hauler things where they're sick for a long time. They can't go back to work. They feel terrible. It's a bad disease. So this is your opportunity to not get it. And I strongly recommend vaccination.
So will vaccinated people continue to test for COVID?
No, they won't. The test we do is a nasopharyngeal test. And so you shouldn't have it in your nose unless you actually have been exposed. You could carry it. We don't think so. The macaque study that I showed actually did show that the animals decreased their carriage rate very effectively. But we have yet to really prove that definitively in humans, but it's very likely that you don't carry it very well once you've been vaccinated. You will have a positive antibody test when you've been vaccinated to COVID. And in fact, we're just going to start a little study at Huntington where we test some of our vaccination people, vaccinés actually, to see if they have antibodies. I'm sure they will have antibodies. So you will have a positive antibody test, but you won't have a positive PCR test.
So there's a question about what if someone has COVID, how long do they need to wait before they get vaccinated?
We usually recommend you wait about 3 months because at that point your antibodies are beginning to kind of maybe dwindle a little bit. You want that little extra boost. And we know that the vaccine is a little bit more immunogenic than natural infection. So, if 2 months, that's perfectly fine. We've had a few people get vaccinated right in the middle of COVID. That happens sometimes. Doesn't seem to hurt them. And you don't have to get two. If you do a Moderna or a Pfizer, you only have to get one of the shots. You don't have to have two if you've had COVID.
Okay, if someone receives their first dose of the vaccine and gets exposed or contracts the virus within days of the vaccination, do they need to retake the first dose?
No. So that person, their second dose was natural infection. So they're probably good to go. They got it all down in one fell swoop.
Okay. One person just making sure they understood you correctly, that cancer patients going through chemotherapy can get vaccinated, or does it depend on the type of cancer?
Well, the chemotherapy, the vaccine's not going to hurt you. The chemotherapy may diminish the efficacy of the vaccine. So if there's a window of opportunity, for example, I have a patient, a young man who has gastric cancer, and he has access, he's a healthcare worker, he has access to getting the vaccine. So we're going to vaccinate him first before he gets his chemotherapy because his immune system's a little more normal when he's going to get the vaccine. And so I wouldn't recommend if you're right smack in the middle of your induction therapy or you're getting really, pretty nasty chemotherapy that's making you sick, that's probably not the time to vaccinate you. Not because the vaccine's going to hurt you, It's just you might not develop the kind of immunity we want to see. So if you have a chance after your chemotherapy or between chemotherapies where your oncologist thinks that your immune system's pretty normal, then that's the time to vaccinate.
Great. Just clarifying, someone who is pregnant can take the vaccine. It is safe.
We think it is safe. We haven't studied it, to the degree that everybody would feel comfortable recommending it. But the American College of Obstetrics and Gynecology feels that it is very safe. Most gynecologists and obstetricians are recommending it to pregnant women. We know that COVID can be very dangerous for pregnant women. They can get very, very sick with it and die. The mortality of women that are pregnant with COVID is higher than the average person. And so for that reason, the benefits of the vaccine really outweigh the risks. It is being looked at right now. The Pfizer vaccine is being studied in 2,000 pregnant women. It does appear to be very safe. It also appears to be safe in breastfeeding. And in fact, actually the antibodies may go to the baby, which might protect them. But we don't have all the data yet, so we can't say it with great certainty, but it appears to be very safe. And certainly the risk of COVID is bad in pregnancy.
You mentioned in vivo effects from the vaccine. What did you mean by that in terms of a pregnant woman? Can it affect the baby in the womb?
Doesn't appear to be. There really aren't that much in vivo. In vivo just means in the body. And the vaccines don't have any kind of interventions or interference with genetics they don't get integrated into your genetics, nor do they seem to be associated with any kind of birth defects. Now, we don't know for sure because they haven't been well studied in pregnant women. That is going on right now. But as I said, 9 individuals during the Pfizer trial and quite a few in the Moderna trial, and I'm sure some in the Johnson & Johnson trial got pregnant during that time period, and there were no birth defects noted in their babies.
What are the implications for the delay in vaccinations for children?
Well, the implications are that we worry a little bit about some of the variants. Could they become easier for kids to get infected? So there is some urgency in getting the pediatric data down. Kids are a source of the virus. And so, if you have the adults are vaccinated, but the kids still are getting it, then that's a source where the virus can replicate and cause mutations. So I think there's a need to get that data pretty quickly. It does appear that it's going to be safe in children and protective. And we do know that although it's rare, this multi-system inflammatory syndrome that happens is catastrophic for children, very high mortality. And so we want to protect kids as much as we can.
Do you think that it will be mandated or required at some point for travel or for going to universities or being on campuses?
Well, in the United States, we can't do that. It can certainly be strongly recommended, but we can't make people get vaccinated if they don't want to be. There are other countries can do that and may be more strict about who can come into the country if they're not vaccinated. So I think that that's helpful to be vaccinated and protect yourself, but it may be required for certain types of travel that you want to go to a place that has a very low incidence. For example, New Zealand. You can go to those countries, but you have to quarantine for long periods of time if you've been vaccinated. I don't know for sure if they've lifted that right now, but that's probably going to be an issue that they can say, now you can come in. So I think it's going to be an important documentation, just like we do with yellow fever, for example. There's some countries you actually can't come into unless you've been vaccinated for yellow fever. So other countries can mandate it. The United States might mandate it for people coming into the country, but we can't make our own citizens get vaccinated if they don't want to.
Thank you. Do other vaccines, such as the polio vaccine, prevent transmission?
No, no other. This is a very specific. The vaccines have to be pathogen specific. There's not overlap between certain vaccines. There's been sort of some interesting studies that looked at the BCG vaccine. Many people have received that, the tuberculosis vaccine, that they didn't seem to get COVID. That's sort of fallen off the radar, but that may have more to do with what that vaccine does to your immune system rather than any kind of activity itself. So there's no evidence that other vaccines will protect you from COVID.
There's been a discussion about a third booster shot. Any thoughts about that?
Well, I hope we don't have to do that because it's just a pain in the neck. Well, it's a pain in the arm, but it's difficult. But that's the beauty of these mRNA platforms, and Johnson & Johnson could do it too, is you just introduce another piece of information and you and you revaccinate. Now, maybe what they've talked about is either doing just a third of the standard vaccine or dial in a different recipe that covers the variants and try to stay on top of it. We might have to do that. And whatever we have to do to end this, we've got to do, because it's just awful. So so we have the technology to do that. I kind of think we're not going to have to do that, but I don't know for sure.
The questions keep coming. We're so appreciative of your time. We'll try and take a few more and then wrap it up. There's a question about the lower cases of influenza this year and whether or not you feel like that could be explained, or do you think they're just not being reported because of the COVID situation?
No, influenza is definitely down, and it's a very simple reason. Everybody's wearing a mask. That's why. So I will tell you, even when COVID disappears, I will never go on an airplane without a mask. I frequently would get upper respiratory infections after I flew. And so, it's just, I used to, myself included, would kind of scoff at, people that would wear a mask when they were traveling, and boy, they were smart. I think that, our influenza rate was way down. We kind of predicted this because we could see it. They had a very low influenza rate in the Southern hemisphere because, their seasons are opposite ours. And so sure enough, we didn't have very much influenza. And it's just because people are masked and much more careful, washing their hands a lot, paying attention to stuff.
Why do you believe young children are less likely to get infected?
We don't know for sure. Their immune systems are different. And perhaps the most important reason is they don't have as many ACE2 receptors. Remember, that's the cell site that this virus attaches to. So kids have far fewer ACE2 receptors. And that may be part of it. They can't carry as much virus. Their immune system is immature, and so it doesn't get as riled up. This virus really stirs the pot of your immune system. It just goes in there and creates havoc. And kids, their immune systems are developing, so they're not as sensitive. And so that may be why, but we don't really know for sure.
Last two questions. Is the AstraZeneca vaccine as effective as the other vaccines?
It is as effective. AstraZeneca, for some reason, they've had an awful lot of troubles. First of all, it was one of the very first vaccine that was really being developed quickly and was being put out. And it looked very good. It's an adenovirus vaccine. It is very good. But they goofed in one of their trials. They inadvertently gave half the first dose. This was in Brazil, which actually turned out to be serendipitous because it seemed like it was more immunogenic. And then they were the ones that had two cases of kind of severe neurologic problems that supposedly were unrelated to it. Their vaccine is not effective against the South African variant, so they're not using it at all in South Africa. And they've had some other kinds of, economic, they were developed at Oxford University, and so the Brexit thing sort of got things screwed up. So the Europeans are all in a huff about it. So they've had a lot of problems, but it's a very effective vaccine. I don't think it's going to be used a lot in the United States because it is a two-part vaccine. We've already got two of those, and we've got Johnson & Johnson. So, but it's good. It's fine.
Last question. If a group of people are in a pod and they're all vaccinated, can they relax the masks and social distancing? They want to know if they can hug their friends again.
We're social creatures, aren't we? This was the worst thing. I think this was worse than some of the other stuff. It's just, we can't hug. We can't, God forbid the French. We spend a lot of time in France and they love to do the French kissing, on each of the cheek. They can't do that anymore. So if you're in a pod and you trust the other members, that they're all vaccinated and everybody's healthy, they don't have influenza or, some other calamity, then yes, you can be a little more careful. I think it's prudent for the next few months to be still kind of careful. Wear a mask, certainly when you're out and not around people that you don't know, or you're around people that you don't know. And just be cautious. My mother's 89 years old. She's very youthful, and she's fully vaccinated, and she has a little house up in the country, and we're going to go up there this weekend. But even while we're there, I can hug her. I haven't hugged her in a year. I'm going to give her a big hug, but I think we're also going to wear masks when we're sort of not eating or being around, when we're close to each other. So I think it's prudent to be very careful until we know for sure if the vaccines are just super good at protecting people. Then you can let things be normal.
Dr. Schreiner, on behalf of the New Horizon communities, the Islamic Center of Southern California, and all of the attendees as I shared up and down the state of California. We so appreciate your time, your expertise this evening. Very valuable information and presented in such a lovely fashion. Thank you again.
It's my pleasure. Thank you very much for allowing me to do it.
Have a good night. Assalamu alaikum, everyone.
Done.